Scoliosis, lateral curvature of the spine. Now, what exactly is scoliosis? What are the different types? And what can be done about it? Now, when we look at the spine, we recognize that we will examine the spine as a manual therapist from the side, thereby appreciating what we call the AP curvature. Here we have the front, the patient facing me, and the posterior, i.e. the back. Looking at it from the side, we have the anterior, posterior curvature of the spine. Now, there should, under normal circumstances, be some curvature of the spine. You can relate to my previous video or refer to my previous video regarding this, where I explained the importance of this. But in a nutshell, when we have reduced AP curvature, i.e. when we look at it from the side and the spine is straighter, there is a greater level of shock that the body actually undergoes in terms of the physical trauma when you're running, jumping and carrying out activities of that nature, as compared when you have some curvature in the spine. That then acts as a shock absorber. The shock absorption therefore minimizes the amount of pressure primarily experienced with the lower segments of the spine. Now, moving to the focus of our video today, I said scoliosis. Now, in order to appreciate scoliosis, we see the patient either from the front and or the back. Initially, my examination generally is examining from the back and then from the front also. That's a complete examination. When doing so, what we see is, instead of seeing a nice straight spine, what we see is some form of lateral curvature, like so. That is what we refer to as scoliosis. Now, as I mentioned, there are different forms. The most common is functional scoliosis, and less common is structural scoliosis. The most common cause of functional scoliosis is a leg length discrepancy, i.e. one leg being shorter than the other. How does that have an impact on the spine? Well, if you consider the pelvis and the actual spine inserting into the pelvic bowl, the pelvic inlets, what happens is the hip joint articulates over here. If I turn it around to the patient facing you, we have these little depressions, what we call the acetabuli, on each of the innominate of the pelvis. The hip bone actually sits in there, articulates in that region, and so if you have one leg longer than the other, you may get a pelvic tilt. Now, if I turn the patient back around, you'll appreciate, as I induce that pelvic tilt, you can see the motion that occurs in the lower part of the back spine, and that curvature then translates all the way through to the top, arguably not only actually finishing at the suboccipital region, i.e. the base of the skull over here, rather it may continue and from a biomechanical standpoint finishes at the temporomandibular joint, which is your last joint. So patients who have TMJ dysfunction may actually have issues emanating not only as far as down into the lower part of the spine as a result of some element of scoliosis, rather all the way down to the feet. Now, keeping here that little curvature at the lower spine due to the leg length discrepancy, as I say, will translate all the way up and to the neck, which may result in headaches also as a potential clinical presentation. When we look at structural scoliosis, To delineate one from the other, there is a very simple manual test that one can perform in the clinical setting, and that will help us to determine if this is structural or functional. Based on that, we can then inform the management. If, however, the scoliosis is very, very common, except not so much to the untrained eye. However, when we have scoliosis which is of significance, i.e. the curvature is significant, in those circumstances an X-ray will prove of value. These situations, when we see, are those patients who have got a very obvious deformity. So, like I say, it's much more common than people think, but the one that is of greater clinical significance is actually picked up a lot sooner in children from 8 to 12 years of age, generally speaking, occasionally missed up to about 16 and then picked up, because of the deformity not only in the spine. You get the lateral curvature, but that's often accompanied by hyperkyphosis, so an increased curvature of the upper back, what appears like a hump. And also, when you look at the patient from the front, you will see some deformity of the chest wall, including a difference in the height of the nipples. And in females, the difference in the size of the breasts. So these are some of the telltale signs and the reason for which it is that we must examine a patient not only from the back in the context of scoliosis, but also from the front. When we then look at structural scoliosis, we perform an X-ray. The X-ray will allow us to calculate something called the Cobb's angle, and if the size of Cobb's angle is greater than 12 degrees, this then warrants a case for surgical intervention. In children, like I say, often picked up in good enough time, and the surgery will usually take place at approximately 16 years of age, whereby the very invasive surgery, by the way, the surgeon will insert two Harrington rods, two titanium rods, all the way down the spine, and adjust that to try and counteract the curvatures that are. Now, that's the surgical case. What about when, in all the other cases, like I say, with it being much more common than people think? So, on a good number of occasions, I will pick up the patient has an element of scoliosis, albeit mild. If it's functional, then we address the functional cause. So, for example, in the context of a leg length discrepancy, it may be beneficial that the patient will have a review with a podiatrist, chiropodist, or otherwise somebody who works in the context of gait mechanics, and so insert an orthotic. In other cases where there's, say for example, a hemivertebra can also cause similar issues, but of course we cannot rectify that or change that. It's all about management. So all the other cases there are specialized clinics that will help you to carry out certain programs. But for me, personally, if there are symptoms that suggest there is some aching or pain in the acute setting, that can be addressed through manual therapy, some very careful bony manipulation as well as soft tissue manipulation. But in the longer term, it's all about developing the muscles of the back, both upper and lower. And the greater work can be done around that, the greater the control of symptoms and management of that scoliosis. Swimming is one of the best exercises. I couldn't recommend it enough. Again, for a whole host of reasons, including but not limited here primarily with the focus of developing the back muscles, both superficial layers, so your trapezius, upper, mid and lower fibers, your latissimus dorsi, your erector spinae muscles, but then also your core, your pelvic floor muscles, and so on and so forth. So there you have scoliosis in a nutshell, what it is, how it manifests, how we can pick up signs for, and how best to manage. Thank you for watching.